Good morning, guys. Sorry for the interruption in the middle of our talk. So I'm Dr. Sankirtana, working as a faculty and administrative team in the PEMS, Preventive and Emergency Medical Sciences. So here I am giving you a small intro to our course. And next sessions, our consultants will be handling the session. So Preventive and Emergency Medical Sciences. So our course, Preventive and Emergency Medical Sciences, is India's first of its kind, which is of 100 days and also of 45 days course, in which we are dealing with preventing and managing of both communicable and non-communicable diseases. So by the end of this course, one will be able to treat patients in rural areas and semi-urban areas as well.
तुम अपने नंबर को दो, हम उससे तेरे नंबर से करेगा। मेरे फोन से फोन नहीं उठाए, व्हाट्सएप नंबर में मैसेज करेगी, बोलिए भी नहीं किया।
Can you all mute yourself?
क्या बोल रहा है मतलब कुछ तो
मेरे को वो दिन बोली आपका व्हाट्सएप नंबर में हम सारा डिटेल्स भेज देगी, फिर दोबारा हम तुम बोलने के बाद
for 2 minutes please mute yourselves, guys. Okay, thank you. So our main vision is we envision in an India where quality healthcare needs are met even in a remote places. So we here train especially family students in a way we can treat every patient in the rural areas. So what is the main reason of introducing a family course in India? To raise the standard of pharmacy profession in India in terms of pharmacy practices, and to provide patient care in cooperation with patients, prescribers, and other healthcare professionals based on the knowledge of therapeutics and evidence-based data. As a family, we have so many of opportunities after our course. So most of us choose to be a clinical researcher or a faculty or a clinical pharmacist. Most of clinical pharmacists mostly. So in spite of all these options, we have introduced a new option to our family. For our family students. So most of the family students have a passion of treating patients. So this course will give a chance to prove yourself in the medical field. So this is an outline of our PMS curriculum. We will be giving you knowledge about our communicable and non-communicable diseases, common emergencies, basic knowledge of our pharmacology, and also management skills in our course. So what will you learn in this course? We will be learning how to diagnose and manage a common disease, educate, screen, and prevent the complications of a chronic diseases. So perform basic procedures like sutures, suturing, wound, IV injections, cannulas, trials tube, and etc. So you will be learning mainly here, know when to manage and when to refer a patient in this course. So every condition of a patient cannot be handled by a single person or a single physician. If you are treating in your place, being a doctor, you should know when to manage a patient and when to refer a patient. So it is perfectly learned in this course by you. So here in our course, our mentors will be of our consultants, our CEO, Sir Dr. K. Somsekhar Reddy, Sir, who is the founder of Soothscare Network, and also Dr. P. Abhishek, Sir, a medical director and consultant general physician, Dr. A. Deepthi Pravalika, ma'am, COO and consultant general surgeon at NEH, and Dr. K. Dinesh, Sir, consultant general physician at Tulsi Multi Specialty Hospital and New Allied Hospital. So these are our faculty members of PEMS, faculty members, and also administrative team of Preventive and Emergency Medical Sciences. So these are some of the testimonials of our students from previous batches. So here is a classic example of our Preventive and Emergency Medical Science course. Thank you for listening to me for this long. And here I will be handling this session to Dr. Dinesh, sir. I would like to take this moment to invite Dr. Dinesh, sir, who is everyone's favorite trainer at PEMS. He hails from Guntur, did formal education in Guntur city, MBBS in NRI Medical College, MD in MD in internal medicine at Dr. Pinamneni Siddhartha Medical College. He has an experience of working in KIMS Hospital and had exposure to varied number of cases. He also had 5 years of teaching experience to MBBS, PharmD, and nursing students. I invite him to give a brief about diabetes mellitus.
Yes, thank you, Dr. Sankirtana, for inviting me. So I hope I am audible to you all. So can you punch your answer yes or no in the chat box so that I can understand I'm audible, I'm visible properly or not? Yes, can you type in your chat box? Good morning, everyone. Yes, Akshara, yes. Yes, very good. So it is a very great day for me to see you all people today for our attending for the webinar. So I think all of you have followed the introduction about PEMS. So I just want to give I'll take 2 minutes once again to tell about PEMS again. So it is mainly intended to start a clinical course for the PharmD aspirants actually. So PharmDs are no way less than MBBS student. Why? Because they are trained in such a way that MBBS students what they are getting trained, all the subjects they are also getting trained. No, so I think all of you are PharmD graduates or somebody who are studying in PharmD or somebody might have passed out from the PharmD. So everybody have learned the topics, but you are not capable of treating the patients. Why? Because less number of exposure to clinical patients. Okay, so that is why we have started this course to impart you the clinical knowledge. Okay, so this is the main motto. I don't take much time in telling once again about all the aspects of PEMS. I'll start my topic for today. Okay, so please go through the session, follow the session properly. I think many people are there from North India. Hello. Please give me a second. So can you see everybody? Yes. So I'll straight away start the topic. Yes, thank you, Robert. So I'll take 1 hour session about diabetes. So even 1 hour is not sufficient to complete diabetes. Okay, it takes nearly few days to complete the whole aspects of diabetes, but I try to minimize all the things and tell you what about all you can learn diabetes in an hour. Okay, so in this one session, I think you might learn many aspects which you might haven't heard previously about diabetes. Okay, so I share you that. So why I have chosen diabetes is it is a very common non-communicable disease. So diseases are classified into communicable and non-communicable diseases. Once if you go through our course, you will know what are communicable and what are non-communicable diseases. So I'll tell them later. So it is one of the most common types of non-communicable diseases, diabetes, and it is a very common disease. So that is why it is, as it is a very common disease, and most of you people you are not confident in treating diabetes, though it is common, though you know about diabetes, you are not able to treat diabetes in your community. So that is why I have chosen this topic. Okay. So how many types of diabetes are there? Can anybody tell? How many types of diabetes are there? Types of diabetes. Can anybody tell what is diabetes? First tell me what other types of diabetes you know.
Type 4, 4 types of diabetes.
Yeah, so that is a common answer that I'll get. So yes, Harika also told type 1 and type 2 diabetes. Is it the right one? Can anybody tell how many types of diabetes are there?
4 types of diabetes. Sir.
What are they?
Type 1, 1.5, type 2, type 3, type 3, type 4.
Very good. So what is type 1 diabetes? All are these diabetes or something else? So yes, so type 1 diabetes, type 2 diabetes, gestational diabetes. And what is type 1.5 diabetes? So can I know who has answered type 1.5, 3A, 3B?
Ketosis, sir. Ketosis cone diabetes.
Yes. Can I know your name?
Robert Wilson.
Yeah, Robert, you are answering. Okay. Okay, Robert. Yes. So diabetes, there are 2 types. What are they? Diabetes mellitus and diabetes insipidus. What all you are telling it is diabetes mellitus. So diabetes mellitus and diabetes insipidus. Okay. So between these two, what is the most common type of diabetes? Is diabetes mellitus. Diabetes insipidus is a very rare form of diabetes. So what all types of diabetes you are telling are diabetes mellitus types. So, but it is not type of diabetes. So, how many types of diabetes are there? There are two types. One is diabetes insipidus, and the other one is diabetes mellitus. Okay. So, then coming to diabetes mellitus, we discuss diabetes insipidus later. Right? Because though it is uncommon, it is an important disease. There are people who can present with symptoms of diabetes insipidus, though rarely. It is a rare disease. But most common type of diabetes is diabetes mellitus. Okay. So can anybody tell what is mellitus? What is mellitus?
Sugar.
Yes, sugar or
Honey.
yes, it is sweet or it is honey. So mellitus means honey. So it is a sweet disease. So which kills the patient sweetly. Okay. Slowly, which kills the patient. So it is a sweet. Mellitus is honey and sweet, otherwise sweet. Okay. So why mellitus has been coined to this disease? Why? Because the person are sweet. Yes. Good morning, Karthik. Okay. That's true, student. Okay. So main important thing, there is a metabolic perturbation in diabetes mellitus. So what is the metabolic perturbation? What is perturbation is nothing but alteration in the normal physiological aspect. It is called as a perturbation. So what is the metabolic aspect of diabetes mellitus? What increases? You forgot? No, Karthik. So there are 32 members in the group. No, I don't know how many Kartiks are there. So I reminded you. You need not keep a sad face like that. So I remember you. So you used to answer me very nicely in the classes. Okay, don't worry. Even now you can answer. Yeah. So increase in. Am I audible properly?
No, sir.
Oh, you can tell me, no? I'll stop my video so that you can hear my voice properly. So I think you can hear my voice properly now.
Yes, yes, sir.
Yes. So the metabolic perturbation that occurs in diabetes mellitus is increase in blood glucose levels. Blood glucose levels increase to such an extent that it causes clinical symptoms. So that is nothing but glucose is a sweet. It is honey-like thing. So that is why the term mellitus has been coined to this disease, diabetes mellitus. Okay. So yes. So we are telling that it is a non-communicable disease. Communicable means it can transmit from one person to the other person with the help of a vector is called as a communicable disease. While there are some diseases which need not have a vector for transmission of a disease, it is called as a non-communicable disease. So diabetes is carried by a vector or what? Is it carried by a vector like housefly, mosquito, or a pediculosis?
Of course
Is
not,
it
sir.
so? No. So it is a non-communicable disease and it is a metabolic disease. Why it is called as a metabolic disease? Can anybody tell? Non-communicable metabolic disease.
Because
Yes.
person will develop intolerance to carbohydrate metabolism.
Yes. So there is a metabolic derangement in the normal physiological process in some people in whom they develop diabetes. So it is called as a metabolic derangement. So what is the main important metabolic derangement in diabetes?
Carbohydrate intolerance.
Okay. So prior to that, I'll discuss what you have told, types of diabetes, so that I can tell. So different types of diabetes will have different types of metabolic derangement. So that's why you have to know what are the types of diabetes mellitus. So from now, if I tell diabetes, it is diabetes mellitus only, not diabetes insipidus. So what are the different types of diabetes mellitus? Type 1 diabetes. So what is the other name given to diabetes? The olden name given diabetes mellitus type 1? Yes. Everybody will be learning this in your school times, no? So type 1 diabetes is otherwise called as insulin dependent diabetes mellitus. Yes, very good. So then what is 1.5 diabetes? What is type 2 diabetes? What is type 3 diabetes mellitus? Yes, Robert, anybody? Harika, can anybody tell what is type 1.5 diabetes?
Yeah, type 1.5. Yeah, basically it's a type 2, sir. Presented as a type 1 actually.
Yes, what is it otherwise called as? So
Ketosis prone diabetes.
Yes?
Ketosis prone diabetes.
No, I'll tell you. So can anybody expand these terminologies? I think nobody have heard of this. Yes, very good. What is LADA? What is MODI? LADA and MODI. Can anybody expand this?
Autoimmune diabetes, sir, in adults. Latent autoimmune disease.
Very good. So LADA is latent autoimmune diabetes in
Adults.
yes, in adults. Then what is MODI? Very good, Karthik. Some modifications to be done. Yes, very good. Anirudh. Oh, Anirudh also joined. Yes. So maturity onset diabetes in younger. So Karthik and Anirudh, they are old students only. They can easily answer. Yes. So latent autoimmune diabetes in adult and MODI is maturity onset diabetes in younger. So can anybody tell what is LADA and MODI? What is the pathophysiology in LADA and MODI? So the term itself indicates the disease. So I will complete here itself. So type 1 is insulin dependent diabetes mellitus. Type 1 is LADA. Sorry, 1.5 is LADA. Type 2 is non-insulin dependent diabetes mellitus. Type 3 is what? Type 3 is what and type 4 is what? Yes. What is GDM?
Gestational diabetes mellitus.
Gestational diabetes mellitus. So gestational diabetes mellitus. So type 4 is pancreaticogenic or pancreatic associated diabetes mellitus. Okay. So first I will tell what are these. Why type 1 is called as insulin dependent diabetes mellitus? Can anybody tell? Nowadays, nobody are using this term for type 1 diabetes. It was coined initially during the initial days of type 1 diabetes. They used to call this as IDDM, but nobody are calling this as IDDM. Why? I will tell you also. So what is IDDM? It is insulin dependent diabetes mellitus. So why it is called as IDDM? Yes, fast. There is no much time. I'll complete the class. If you answer the questions, I'll complete the class faster. Yes. So complete absence of insulin production. Why? So Karthik is correct. So as there is complete absence of, sorry?
Destruction of beta cells. Okay,
Very good. So what are the causes of destruction of the beta cells that led to complete absence of insulin production? Can anybody tell? So Robert Wilson is telling that, yes, very good. Yes, very good. So most of you people are answering very nicely. Yes. So how many types of pancreatic cells are there? Pancreas is what? What is that organ? Pancreas. Insulin is the only drug of choice of treatment due to beta cell destruction. That is why so you are telling it as insulin dependent. So the only treatment for type 1 diabetes is only insulin. That is why it is called as insulin dependent. Yes, it was the older concept, but the concept has been changed. Yes. Yes, 4 types of cells are somebody are telling. So what are the 4 types of cells? So first, what is pancreas? What is pancreas? It is a flat It is a flat organ which is situated in the upper abdominal region. Okay, it is a flat organ which is situated. This is pancreas. Okay. So how many types of cells are there in pancreas you are telling? So it is a mixed organ. Pancreas is a mixed organ. It means it contains both exocrine part and endocrine parts. So there are two parts of the pancreatic tissue. One is exocrine part, the other one is endocrine part. So the exocrine part is called as acinar cells. So the major chunk of the pancreas, is it exocrine or endocrine? Please tell me. The major chunk of the pancreas is made of exocrine tissue or endocrine tissue? Please answer. Endocrine. Krishna is telling endocrine. What about others? Please type your answers. Endocrine. Karthik is telling. Yes, others. Please type your answers fast. So the pancreas is mainly made of which part? Is it endocrine or exocrine? So how many people are there? There are 28 students. So only 2 members have answered this question. Please,
No
please.
idea, sir.
No idea. Yes, 3 answers. So at least tell that and type your answer. Exocrine. Harika is telling exocrine. What about Saif? There are no names here. Sandra, Sandwana, Adnan. Yes, exocrine, endocrine. Harika. Yes. What about others? Madhuri, Krishna has answered. Jency, yes, endocrine. 15. Aksa, Akshara, Anirudh, Feba, Jose. Yes. So very good. So most of you have answered this question, but what is the correct answer? Now I will tell you. So most of the pancreas is exocrine only. Exocrine, not the endocrine part. Okay. Most of you people have told the pancreas is an endocrine tissue. No. A few bit of the pancreas is only endocrine. The rest of the whole pancreas is exocrine part. So what is the main function of the pancreas by the exocrine tissue? What does it do? Pancreatic acinar cells secrete what? No, not endocrine. Sheikh Adnan. It is the exocrine part. Only a little bit of the pancreas is endocrine. Okay. So what does pancreas secrete? So from your school days, you have learned that no. What does pancreas secrete? No, not
Digestive
bile
enzyme.
juice.
Digestive
what?
enzyme. Digestive enzyme.
Yes, what is that? It is not bile juice, Krishna. It is some other juice. So the bile juice is secreted from where? Okay, pepsin. It is also a digestive enzyme. So what it secretes? One juice it secretes other than bile juice. It is a pancreatic juice, no? So the pancreatic juice, yes. So the pancreatic juice is secreted from where? It is secreted from
Exocrine part of the pancreas.
Is that Pooja?
Yes, sir.
Okay. Okay. Yes. So acinar cells secrete pancreatic juice. While the endocrine part of the pancreas. So the pancreatic juice contain what? Amylase. Yes. Trypsin.
Lipase.
Yes. Lipases. So very important enzymes. They are lipase, amylase, These are very,
Protease.
very important. Yes, trypsin, chymotrypsin, all these are secreted by the exocrine part of the pancreas that secretes pancreatic juice, which contains all these enzymes. Okay, they help in digestion of the food. Okay, so a small chunk of the pancreas is made of endocrine tissue. Okay, so this endocrine part of the pancreas is called as what? Yes, very good, Harika. Endocrine part secretes hormones, while exocrine pancreas secrete enzymes. Pancreatic juice, it contains enzymes. So endocrine part of the pancreas is called as what? Called as what? So written already here, partially. Yes, it is called as islets of Langerhans cells. Okay, so these islets of Langerhans cells, they are scattered within the exocrine part of the pancreas. So like this, islands of the endocrine part is scattered among the exocrine part of the pancreas. So like this, but most of the endocrine part is located at the tip of the pancreas tail. This is called as pancreatic tail. So this is the main part. So everywhere the endocrine cells are present, islets of Langerhans, but the islet, that's very good. Anirudh good, Karthik good. 1+, I don't know the name, so you're also good. So answer nicely, Langerhans. So the tail of the pancreas, this is called as the tail of the pancreas. So Langerhans cells are concentrated in this part of the pancreas more and compared to the other parts of the pancreas. This is called as the body of the head of the pancreas. This is called as uncinate process. This is called as body. Okay, this is called as tail. These are the parts of the pancreas. This is called as uncinate process. Uncinate process. This is head of the pancreas. This is called as body and tail. So the tail is the organ. The tail is a part of the pancreas where the endocrine tissue, that is the islets of Langerhans, are concentrated more when comparing to the uncinate head and body of the pancreas. Okay, this also has an importance. Why? Because some tumor relating to the pancreas, which is situated at the tip of the pancreatic tail, if we remove that part partially, so the chances of that person becoming diabetic is more. Okay, why? Because the endocrine part is mainly concentrated in this part of the pancreas, tail of the pancreas. So that has a significance. Okay, so the islet cells of Langerhans, so they contain how many types of cells? How many different types of cells are present in this endocrine islet cells of Langerhans? Can anybody tell? How many types of cells are there?
Beta, gamma, and delta cells.
Yes. Yes. Anybody other answers from anybody? How many types of cells? First, tell me the number of types of cells. Yes, very good.
4 types.
Yes, 4 types of cells are there. What are they?
Alpha,
cells,
beta, delta, PP cells.
beta, delta. Yes. So, what are the alpha cells secrete? What does the alpha cell secrete? Very good, Krishna. So, alpha cells secrete what?
Glucagon.
Yes, very good. So, F cells, where are they present, Anirudh? I think F cells are not present in pancreas. F cells are present where? In which endocrine organ F cells are present? F cells are follicular cells or parafollicular cells. These are present where? So thyroid is made of 2 types of cells. What are they? SNR cells. They are called as follicular cells. Like this here, SNR cells which secrete the enzymes, pancreatic enzymes. The thyroid is also made of follicular cells and parafollicular cells. Parafollicular cells are otherwise called as F cells. Okay, they secrete a hormone called as calcitonin. Okay. Okay. Yes. The SNR cells of the thyroid secrete thyroid hormones. So here in the pancreas endocrine gland, alpha cells secrete what? These are very, very important. That's why I'm taking much time in discussing this. So normal physiology. So first, unless you know the normal physiology, can you try any medicine to alter that physiology? Can we do that?
No, of course, no.
Yes. So the basis of any drug development is to know the pharmacology, physiology first. Okay. So if you are strong enough in your physiology, yes. So there is some disturbance coming from body. Please mute yourself. Can you mute? There is some disturbance. Yes. Yes. So that is why I'm discussing much about physiology here. So alpha cells secrete what? Glucagon. So what is the so first tell me the beta cells secrete what?
Insulin.
Yes, very good. Very good. Krishna, Neeraj, good. What does the delta cells secrete?
Somatostatin.
Yes. What does the gamma cells secrete? Yes. Pancreatic polyp. Yes, yes. Correct. Puja, correct. Puja only, no? Yes. So these are very important. These are very important. Pancreatic polypeptide is important in incretin pathway. So incretin pathway, do you know what is incretin pathway in diabetes? Everything now, treatment of diabetes is incretin only. Incretin pathway. Anybody know what is incretin pathway? So it's very, very important. Nowadays, for the past 10 to 12 years, we are directing this pathway for treating diabetes. So for the past 50 years and 60 years, from the beginning of the era of metformin and sulfonylureas, so insulin, sulfonylureas, biguanides. So these are the starting drugs for treating diabetes. No, so they have ruled the industry for treating diabetes for 5 to 6 decades. But nowadays, we are mainly targeting this incretin pathway for treating diabetes along with the age-old drugs like metformin and some sulfonylureas. So this is a pathway which is very important here also. An enzyme, a hormone pancreatic polypeptide, which is very important. Okay. So that is also secreted by pancreas. One of the incretins secreted by pancreas only, not all the hormones in the incretin pathway are secreted by pancreas, but most of them are secreted by the gastrointestinal tract, which which fall into this category of incretins. Okay. Yes, very good, Anirudh. So these are the DPP4 inhibitors and SGLT2 inhibitors, not SGLT2 inhibitors, DPP4 mainly. DPP4, but not SGLT2 inhibitors. SGLT2 inhibitors are what? Can anybody tell? Yes, Karthik, DPP4, but not SGLT2. Yes, very good. SGLT2 means sodium glucose transporter, co-transport 2. They are MPA, DAPA. They act in the kidneys, but incretins are mainly in the gut. Gut means GI tract. They are DPP4 inhibitors. Okay, and GLP-1 analogs like liraglutide, semaglutide. Please mute yourself, somebody. Yes. So what is the function of glucagon? So which book you have studied in your biochemistry in first year? It is U. Satyanarayana and Chakrapani only, no? Yes. So have you read the topic of insulin in U. Satyanarayana? In biochemistry, there will be a nice depiction of the insulin and its action. Have you seen that? That book depicts insulin physiology very nicely, like glycogen to glucose. So it is a function of what? Glucagon or insulin? Krishna? So which hormone converts? Yes, very good. So it increases the blood glucose levels indirectly. So by converting the glycogen in the liver to glucose. So please go and see in U. Satyanarayana book, the function of insulin. So they depict it very nicely that They're the only one hormone which controls the blood glucose, that is decreases the blood glucose level, is insulin. Rest of all the hormones like thyroid hormone, growth hormone, corticosteroid, glucagon, catecholamines, everyone is opposite to insulin. That is, they raise the blood glucose levels. So they depict the insulin as elephant. So tug of war between the animals. Okay. So one side is the elephant pulling the tug. Okay, that is insulin. The rest of all the other animals pulling the tug to opposite side from the elephant. That is insulin. So the rest of all the animals, they are depicted as hormones like catecholamines, glucagon, corticosteroid, thyroid, growth hormone, etc. So every hormone in the body try to increase the blood glucose levels, but the only hormone which controls, that is which decreases the blood glucose level, is only insulin. Okay, so please go and refer the chapter. I think the chapter number is 62. Ma? So in Satyanarayana book, I didn't remember correctly. Insulin topic, diabetes mellitus topic 62. I think chapter number 62. I'm not confident. So please go and read. Okay, so that figure is given in the book. So glucagon, as I told, insulin is the only hormone which decreases the blood glucose level, while the rest of other hormones are the ones which increases the blood glucose. So main important hormone which antagonizes the insulin action is glucagon. That is also secreted by insulin pancreas only. Alpha cells secrete glucagon, which increases the blood glucose level. Please mute yourself, somebody. Yes, so insulin is the hormone which decreases the blood glucose level. Okay, so coming back to the types of diabetes. So what is the pathophysiology in diabetes mellitus type 1? So we are telling that diabetes mellitus is a metabolic disease which increases the blood glucose level. So which hormone problems can increase the blood glucose level? Either decreased insulin or increase in other hormone excess production, because the glucose level elevation, isn't it or not? Everybody, are you following or not? Please type your answers, yes or no.
Following.
Yes, following. What about others? Krishna, yes, following. Obviously Anirudh and Karthik will follow. Why? Because they are old students only. They'll follow. I know about them, so they'll tell us obviously. Yes, Sheikh Adnan, yes, good. Akshara, good. Yes. So everybody are following, right? Good. Jency, good. So we are telling that diabetes mellitus is a metabolic disturbance, metabolic derangement in which there will be increased blood glucose level. That can be because of decreased insulin production or excess production of rest of all any hormone. So, but main thing which we are telling that blood glucose is maintained by is insulin. Insulin is the main core hormone which regulates the. So somebody have told, I think Robert told. So carbohydrate metabolism is maintained by insulin. So there are other hormones also which maintain the carbohydrate metabolism, but main hormone is insulin. So insulin decreases the blood glucose level. What is the main function of insulin? Is it pushes the blood glucose from the vessel into the cells. Okay, cells contain insulin receptors which, so if the insulin acts on the receptor, that opens the glucose channels, so that from the vessels the glucose present within the bloodstream enters into the cells and utilized it for metabolism. Okay, that is the main function of the insulin. So it pushes the glucose from the vasculature into the cells for utilization in their cellular metabolism. So if there is a disturbance in insulin because of some metabolic derangements, whatever might be the reason, whatever it might be the genetic cause or something that leads to increased blood glucose level. So there are different mechanisms by which there can be increased blood glucose level in due to insulin disturbances. Okay, so they fall into these different types of diabetes mellitus. Okay, so what is the pathophysiology in type 1 diabetes, insulin dependent diabetes mellitus? So somebody have told what is that mechanism? So something is problematic here. 1 second, please. Yes. What is the pathophysiology of type 1 diabetes? Insulin dependent diabetes mellitus. What is the pathophysiology? So somebody told it is autoimmune. Am I audible to you? Everyone?
Yes, sir. Yes.
Yes. So it is break outunda. 1 second. Am I audible now properly?
Yes, sir.
Yes. So it is autoimmune in nature. Type 1 diabetes is autoimmune in nature. So what is the autoimmune disease leading to type 1 diabetes? Can anybody tell? There are different causes of autoimmunity in type 1 diabetes also. What does it do? What does autoimmunity do to cause diabetes mellitus? Please tell me. So please be fast.
Destruction of beta cells. Sir.
Yes, very good. So beta cells are the ones. 1 second, please. Yes. So beta cells are the ones which secrete insulin, and insulin is the hormone which regulates the yes. So so these what are these? I'm telling. So beta cells are the ones which are secreting insulin. So if the cells secreting insulin are destroyed, what happens to the insulin production? So beta cells are the ones which are secreting insulin. So if the beta cells are not there, so what happens to the insulin levels?
Insulin deficiency.
Yes, insulin deficiency will be there. So if there is insulin deficiency, what happens to the blood glucose levels?
Keep on elevating.
So it keeps on elevating. So the autoimmunity. So can anybody tell what is an autoimmune disease? What is autoimmune disease? What is immune? So generally, immunity is the one which is imparted to our body to fight against a particular antigen coming from outside. So that is immunity. Yes, good, Harika. Hyperglycemia occurs. So, but what happens? So some cells in the body, they act as antigens itself against ourself. So such antigens which are present in our body itself, but acting against our against ourselves, they are called as autoantigens. Okay, though present in our body, they are called as self antigens. So our immune system thinks that these antigens are not our antigens; they are coming from outside. So we have to attack them. So beta cells are one such victims. So the beta cells of the pancreas are one such victims of our autoimmune disease system. So our immunity thinks that these beta cells are not self proteins, and our immune system try to destroy these offending antigens. So though these are our proteins in nature, our immune system thinks these are outside ones. They are called as self antigens, and the immune system try to destroy these cells. So as the beta cells are they keep on getting destroyed, insulin production will be coming down to such an extent that the carbohydrate metabolism cannot be done properly, and blood glucose levels continuously goes on rising. So What are the causes of autoimmune destruction of beta cells? There are many causes. One is genetic cause. The other one is infectious causes of autoimmunity. So some diseases, some viral diseases like measles, herpes simplex virus, Coxsackie virus, HIV, Epstein-Barr virus, all these viral infections, they can, and mumps virus, they can go and destruct these beta cells and can lead to type 1 diabetes. So type 1 diabetes is not only because of autoimmune destruction of the beta cells by our own immune system, but also by some other causes like infectious causes of type 1 diabetes. They are viral infections, mainly measles, mumps, Coxsackie virus, herpes simplex virus, HIV. So all these can destruct the beta cells, and there will be complete absence of the insulin in the body, leading to increased blood glucose. So this is the metabolic derangement that occurs in type 1 diabetes. So that is why there is near total or complete insulin deficiency. That is why we have to give insulin from outside. Exogenous insulin should be given to that person to cope up for these increased blood glucose levels. To control these blood glucose levels because of the near total or total absence of the insulin, we have to give insulin from the exogenous source from outside. That is why type 1 was used to be called as insulin dependent. That means the person with type 1 diabetes is dependent on insulin for controlling the blood glucose. Diabetes mellitus is increased blood glucose. No. So this type 1 diabetes is dependent on the insulin for controlling the blood glucose. That is why type 1 is called as insulin dependent diabetes mellitus in the olden days. But nowadays we are not using this terminology for type 1. Why? Because there are some drugs we can use, oral hypoglycemic drugs we can use in treating type 1 diabetes other than insulin. That is why we are not using. But even now, the only first and foremost option to treat type 1 diabetes is though insulin. There are other OHs we can give to treat type 1 diabetes. That is why type 1 is nowadays not called as IDDM. Understood? Everybody understood or not? Everybody, autoimmune. Yes, autoimmune is body attack our own cells. Yes, very good. Yes, understood. Yes, what about others? Yes, good. What about others? So, yes, Sheikh, very good. Sheikh. So that is about type 1 diabetes mellitus. Then coming to type 2, then I'll tell about 1.5 GDM and 4. So non-insulin diabetes mellitus. So type 2 is otherwise called as non-insulin diabetes mellitus. So what does it mean? So here we are telling insulin dependent. Here non-insulin dependent. What does it mean? So it means that the person does not need insulin for treatment of diabetes mellitus. Is it so?
No.
No. Then what? It means the person not only needs insulin, the person not he can be treated with other drugs, not only with insulin. Okay, it doesn't mean insulin does not work in him. It means that we can treat the diabetes with other drugs also, not only with insulin. So that is why type 2 is called as non-insulin dependent. So can we use insulin for treating type 2 diabetes? Insulin works in type 2 diabetes or not?
Works, sir, yes.
Yes. What about others? So insulin works in yes, it will. Krishna is telling yes, it works. Yes. So you shouldn't confuse that non-insulin dependent means you should not give insulin in them. It means that not only insulin, there are other drugs which can treat type 2 diabetes also. It means that. Understood? Yes. So there are many other drugs like OHs and insulin for treating type 2 diabetes. So then what is the main pathophysiology for type 2 diabetes? What is the pathophysiology?
Insulin resistance, no insulin resistance in type 2 diabetes.
Yes, very good. So what is insulin resistance? So in your pharmacology, you have read about resistance. Microbiology also have read about resistance. So here, what is insulin resistance? So what is insulin resistance? This is the main important core pathophysiological factor in in type 2 diabetes. So I'll complete types of diabetes, and I'll stop. So I think many factors I think you don't know have been covered till now. I think many. Okay, I'll tell you. I'll complete in 10 more minutes. So insulin, what is insulin resistance? So it means that there is insulin in type 1 diabetes. There is complete or near complete absence of insulin. But here in type 2 diabetes, there is no scarcity of insulin. So insulin is there in the body. Insulin is produced from the beta cells. Beta cells are not destroyed, so that insulin is produced. Okay. Insulin is produced but cannot be utilized by the cells. Very good. So yes, very good. Krishna, Anirudh. Yes, very good. Harika. Yes, very good. Sridevi. Sridevi has also joined. Yes. So it means that insulin is produced from the beta cells, but the cells cannot utilize the cells are not sensitive enough for the insulin to act upon them. That is called as insulin resistance. Okay, cells become resistant to insulin action. Okay. So what are the factors for insulin resistance? It is a very important thing what I have told. So in the starting, diabetes mellitus is what disease? It is a non-communicable disease. So these are lifestyle diseases. DS means disease. So most of the non-communicable diseases are lifestyle related diseases. Okay. So sorry, am I audible?
Yes, sir.
Yes. So lifestyle related disease. What are the lifestyle related diseases? How many of you like burgers and pizzas? Burger, pizza, nachos, Subways. Huh? Huh? We all like, yes, including me. Yes, zero hate. Very good, nice answer. So they are from where? So pizza, is it an Indian snack, Indian food? Burger, is it an Indian food? So whatever Indian food, how many, I don't know how many North Indians are there, how many South Indians are there. I'll tell some Andhra recipes. Yes, no. So they are not from India. So they, what all we contain are like our traditional foods like jantikalu, something like that, no? Harisalu, like that. But pizzas and burgers are not from India. So all these are the ones which contain lots and lots of cheese in them, no? Which contain lots of calories in them. Okay. So these, so sedentary lifestyle, sitting and doing work after the advent of software companies, so IT jobs, we are continuously sitting and doing our work without doing physical activity. So previously, because of mainly India is an agriculture country, no? So they used to do farmers used to farm the fields and come home. So they will be having physical activity. They are not sedentary. Yes, but nowadays, because of the sedentary lifestyle, because of jobs and all, IT employees, IT jobs, even as doctors continuously sit and see the OPs, no? Not roaming around. So that is sedentary lifestyle. And the other one is foods rich in high calories, like pizza, burger containing cheese and all-purpose flour, maida. Okay, so they contribute to the occurrence of insulin resistance. Without the physical activity in our muscles and the cells, they are not responsive to the insulin action over them. So lifestyle factors such as less physical activity, unhealthy life, obesity can contribute. Yes, very good. That is non-communicable factor. Factors of insulin resistance are hereditary, family history, overweight, sedentary. Yes, so all these are the ones which are contributing to the insulin resistance. Okay, That is type 2 diabetes. So mainly for treating type 2 diabetes, we should start insulin and OHS in the first sitting itself, or something we have to advise the patient. Is there something we have to advise the patient for treating type 2 diabetes, or simply telling the patient to take four n number of OHS and a few shots of insulin that will cut down the blood sugars? Is it enough? Yes, lifestyle change, lifestyle modification is the one very important advice that should be given to the patients with type 2 diabetes. Why? Because insulin resistance is because of these lifestyle changes. No, so I'll tell you the classification. So diagnostic criteria. So diagnostic criteria. Delta means diagnostic criteria for diabetes. So can anybody tell the diagnostic criteria for diabetes mellitus? So there are, how much is the fasting sugar? How much should be the
100, sir.
FBS? How much? PPBS? How much? And HbA1c how much? To tell it as diabetes, I'll tell. So first you have to know the normal and pre-diabetes and diabetes mellitus. So normal FBS is less than 100, very good. OGTT, no, we need not do that. And PPBS, it is less than 140, and HbA1c it is less than 5.7. All these are normal. Pre-diabetes is, so if it is 100 to 120,
125.
and yes, 125.
2 hours post lunch is 140 to 200. Like
This is 5.8 to 6.5.
6.4.
So diabetes, it is more than 6.5. This is more than 200. This is more than 125. Okay. So this is the factors. So we are telling that the HbA1c more than 6.5 is diabetes. So if a person with type 2 diabetes came newly diagnosed with the HbA1c value of 10, so we'll advise OHS, that is oral hypoglycemic agents and insulin for treating them. No, so without advising them to follow the lifestyle changes, very good. HbA1c 4 to 6. No, it is 6.5. So mere lifestyle modification with diet and physical activity will decrease HbA1c from 10 to how much? Can anybody tell? It can decrease 1.5 to 2% of HbA1c reduction can be there. With just without OHS and insulin, the patient follows diet and physical activity. Without OHS and insulin, if strictly they followed, it can come from 10 to 8. Okay, so that is the importance of lifestyle modification in treating type 2 diabetes for bringing down the insulin resistance. Okay, yes. So this is something about diabetes. I can talk for few hours more. So there are many things I can talk about insulin. So I wanted to talk about LADA, MODI, CDM and all. So I'll just stop here because already it is 12:30. Another talk is also there. So I'll stop here. I'll give 5 minutes for you to ask something about diabetes. If you want to ask any doubt, few questions I will answer. Till now, is it understand? Did you understand till now what I have taught you? Is it interesting, boring? Already everything you know about diabetes till now? Yes, I want your answers. Hmm? Hmm? Yes. So please tell your answers. Is it okay? Any new points you have learned? Or is it boring? Yes, very good. Jency, thank you. Yes, Sheikh, thank you. Hmm. Hmm. what to do and what not to do in hypoglycemic conditions of a patient. So in hypoglycemia, main thing is first we have to restore the blood glucose level. It is a very important condition, hypoglycemia. Severe hypoglycemia is called as the neuroglycopenia if the blood glucose levels are less than 40. So hypoglycemia is called as less than 70 milligrams per deciliter hypoglycemia. Severe hypoglycemia with neuroglycopenic symptoms, it is less than 40 milligrams per deciliter. Okay, so in such condition, the patient can go into coma. He first throw a seizure and he can go into coma. So we have to restore the blood glucose from that very low values to normal values. Then what we have to do is, if the person is not severely comatose or the person has no cranial symptoms of hypoglycemia, we advise them just symptoms of hypoglycemia. We'll advise what are the symptoms of hypoglycemia: palpitations, sweating, shivering, headache, reeling sensation, everything. All these are impending sensation of dooming. All these are symptoms of hypoglycemia. So if the person is able to tell all this and he can feel all this, we advise them to take 2 to 3 spoons of a glucose powder, or 2 to 3 spoons of sugar, whichever is available, or 1 or 2 chocolate he can chew in his mouth, or if a sweet is available with him, he can take and eat. Okay, so that is the thing we have to do in case of hypoglycemia, but not so severe. But if the hypoglycemia is so severe, we have to secure an IV cannula, and then we have to start giving infusion of 25% dextrose. So 50% dextrose is also available, but is not available in India. In US and in other Western countries, 50% dextrose is available. But in India, only 25% dextrose is available. Strong dextrose solution is 25% only. So we secure an IV cannula and we infuse 25% dextrose, and we check again the blood glucose levels. If they are increasing but low only, we can give one more shot of 100 ml 25% dextrose, and we check the response of the patient with increasing blood glucose. So that is the thing we have to do in hypoglycemia condition. What not to be done is, if the patient is in comatose condition, we should not advise them to feed like food or something like idli or dosa, something. We have to advise to take which are soluble easily and enter into the bloodstream. That we have to advise, and we should not advise them to eat any solid food which takes some time for increasing the blood glucose values. Okay, that is the thing what we have to do and what we should not do in hypoglycemia. Okay, Krishna? Can a type 2 diabetes using insulin as drugs be de-escalated? Yes, we can do. So this is a very interesting thing. So only insulin will not work in type 2 diabetes. Without OHS, the person will not respond. Why? Because there are groups of oral hypoglycemic agents which decrease the insulin resistance. Only insulin will not decrease the insulin resistance. So if you prescribe only insulin to type 2 diabetes patients, it will not work properly. So though you go on increasing the insulin dose without any OHS, hundreds and hundred units of insulin will not work in type 2 diabetes patient unless you start a OHS. But once you start a OHS, simply metformin, very low dose also, the insulin starts working. Okay, that is the main important thing. So can a type 2 diabetes using insulin as drugs be de-escalated to oral? Yes. So we can decrease the insulin dosing when we start OHS, or if we add insulin to OHS, we can decrease the insulin dose also. Vice versa can be done. Okay, understood, Harika? If one is added to other, the dose of both can be decreased. Yes, very good. Any other doubts? Yes, I think the session is interesting. And all of you have followed properly. So I will cover the rest of the topic in our regular classes. Whoever want to join the PEMS can follow these classes. Okay, and any doubts you can bring to the admin. You can find out, and we will be available at any time to answer your questions. Okay, and I will thank you here and hand over the mic to the other consultant to continue the session. Okay, thank you, Krishna. Thank you so much. Okay, yes, somebody want to ask any question? Yeah, thank you, Harika. Okay, yeah, thank you. I'll hand over the mic to Dr. Abhishek. He will continue the class. Thank you so much.
Thank you so much, Dr. Dinesh sir, for letting us know the novel aspects of diabetes. So, how many of you like Dr. Dinesh sir's session? Please let me know in the chat box. Is that boring or interesting? I think no one enjoyed Dinesh sir's class. Only Krishna. Yeah. Yeah, thank you, Robert. Okay, thank you. Thank you so much. So just as Sankitana said, our course is a 100-day course ideally. So for those who can't relocate to Guntur, we are providing 45 days virtual program. And for those who can't dedicate their 100 days for this course, so we are providing 45 days intense program. So for the working professionals, we are providing pre-recorded sessions. So based on your experience with this kind of similar courses, what do you think is a reasonable price range for this course? Can anyone let me know in the chat box? And we have 3 dedicated consultants, the dedicated consultant faculty, 2 are general physicians and 1 is general surgeon. And we also have guest lectures from other consultants from various departments. Yeah, okay, Krishna, that's fine. So what do you think is a reasonable price range for this course? What is the price range? What can be the price range for this course? Krishna, can you tell me what can be the price range for this course? Okay, around 5 to 7. Okay. Okay. Anyone? Priceless for the dedication. Thank you so much, Robert Wilson. Any other student? Anirudh, Kirtana, Harika, Chaitanya. Okay. We will let you know about the price at the end of the session. So now another faculty who attracts students with his teaching by starting the classes with interesting case scenarios. I invite Dr. Abhishek sir, who also hails from Guntur, did formal education in Guntur, MBBS and General Medicine from Guntur Medical College. He is a member of the Association of Physicians of India. He also helped more than 10,000 patients during his career and discharged his duties as a COVID warrior. He also has a teaching experience of 3 years to nursing staff, MBBS and family students.
I'd like to invite Dr. Abhishek sir to explain a case of pneumonia.
Okay, good afternoon, everyone. So, where is the pen? Okay, right. So, before starting session, there are around 18 participants, right? So, these guys responding, you're asking questions like Devin is asking questions. I see a dull crowd here, actually. How many of these guys are responding? Am I teaching to dull students or were they active? Active only. Okay, very good then. So let's not make this a dull session and let's make it a very interactive session. So you can ask your questions or type your things in the chat box in the session below. So we'll with that we can start. So if you're active, just press active in the chat box below and let me know if you're active or sleeping because of this did the hypoglycemia hit you guys in the afternoon freelance session? Active, good. So before starting, where are you guys from? Krishna, you can open, some of you guys can open your mics, or some of you guys can type in the chat box below where you guys are starting from, coming from, or listening from. I'm from Tirupati. Good. Only 3 people have responded. What about the rest? So Harika from Hyderabad. Good. Very good.
Good afternoon, sir.
Yeah. Good afternoon. Yeah. Well,
Robert Wilson here
okay. Robert
from Mahbub Nagar.
Mahbub Nagar. Very good. What about the rest? Most there are 18 participants here. Most of them are sleeping, I think. Fine. So working as DMO in multi-specialty hospital. Very good. Warangal. 1+. Who is 1+? You know his name. Raichur, Karnataka. Very good. So we have many students from other states also. Very good. Karthik from Nellore. Good, good. So what are you guys doing? So working as DMO, somebody is working as DMOs. What about the rest? Okay, fine. Nellore. So DMO, okay. Okay, good. Right then. So let's start the session. Let's start with the usual case scenario. So how many of you guys were asked the questions like you're called doctor by your family, right? So how many of you guys can treat your own parents or your brothers or siblings? How many of you guys are confident enough to prescribe some medications? So how many of you guys are very confident on prescribing which kind of medications and giving medical suggestions to your family? On the intern, very good. So interns also have joined. Hope I'll treat. Okay. You will, Krishna, you can. Right. So nobody is confident. Okay, right. So I will. Okay, good. Seeing only few people are responding, not more than that. Fine. So, okay, start. So let's start session 9. Right then. So 60-year-old male patient came to your hospital or clinic or whatever may be the setup. Whatever may be the setup, came to your clinic with complaints of cough, cold, fever, body pains since the last 3 days. Now, what will you suggest? What will you do? This is the question. So I'll Harika. Very good. Okay, 60-year-old male patient came to your hospital with complaints of cough, cold, fever, body pains. So you want to check vitals? Okay, good. That's a good thing to start. So this fellow BP is around. So what are the vitals? Can anybody name all the vitals that we check? Mainly temperature, SpO2. Okay, temperature is a part of vitals. Good. So temperature, SpO2. What if you don't have the probe? And SpO2 is also a good measure, but in previous days there won't be like SpO2 probes are very famous only after the COVID and all. Previous days these SpO2 probes or pulse oximeters are not that widely available. Okay, anyway, so, what if there is no pulse oximeter with you guys? So what will you count then? Temperature, BP, SpO2, pulse rate. One more thing is there. What is that? So very good. So respiratory rate. So SpO2 means saturation only. Saturation. So there are many conditions where respiratory rate is very high, but saturation is normal, around 98%. Okay, so don't take saturation itself as if the saturation is 98%, then don't take it as normal. So you have to correlate clinically with the respiratory rate and all. Okay, understood? Now for this fellow, let's say BP is around 90/60. So temperature is around 101 degrees Fahrenheit, and pulse rate is around 101 per minute. So respiratory rate is around 24 per minute. Okay. What? So you have checked the vitals. Now what do you want to do? So have to collect history. Okay. COPD, PTB, PTD or PTB. It's pulmonary tuberculosis, right? TB, tuberculosis. Yeah. So have to collect history. So what kind of history do you want to ask? So asthmatic, asthma history. No, this fellow is not an asthmatic. Okay, non-asthmatic. First you want to ask for previous history. Okay. Description of fever, cough. Very good. So somebody said description of fever and cough. So any allergies? Okay. Allergies. Okay, fine. This fellow doesn't have any allergies. What more? What more? Any surgical history? Okay, fine. Any surgical history, family history? Okay, all these things are fine. So before starting that, won't you ask for the history of the presenting illness itself? What about the cough, cold? So as somebody has said, like, yeah, then symptomatic treatment. Okay, fine. So let's not go that far. Symptomatic treatment. Let's go stepwise manner, in a stepwise manner. Okay. So the first thing to do is ask for the history of present illness. Let's not go into the past history. Let's explore the present history first. So in the presenting complaints are cough, cold, fever, and body pains, right? So for any symptom, yes. So how many days? Since 3 days. So okay. So before going for the past history or family history or surgical history, first we need to explore the present history. Okay. The present history consists of cough, right? cough. So what are the things that you need to ask in a case of cough?
It is productive or non-productive?
So whether it is productive or non-productive. So productive cough or non-productive cough. So next, so for any symptom, yes, sputum in itself is a productive, sputum or productive. Okay, both are synonymous. Fine. Yes, yes, we will ask all the blood clots. So before going into that specific topic, so let's understand what are the things that we need to ask for any kind of symptom. There are certain basic things that we need to ask, starting from onset. What is the type of onset? Duration. So for how many days, for how long this fellow is suffering from so and so symptoms. Next thing is progression. How is this progressing? Is it worsening, or does this fellow is feeling better when the days are going? So how is this progressing? Is he feeling worse or is he feeling better? Okay. Next, any aggravating factors? Are there any factors that are aggravating this kind of symptom? So next thing is relieving factors. Are there any factors that are relieving this condition?
Some variations.
Sorry, somebody is asking, but it's a little unclear. Can you repeat?
Variations, sir.
Yeah, variation. Next thing is seasonal variation, or next diurnal variation. So seasonal variation, diurnal variation. Why are these so important? Why do we need to ask all these things? Next, coming to this types. So next thing is type. Which type of this? What is the characteristic feature of this thing? Okay. So type comes to be around productive or non-productive. If it is productive, what is the quantity of sputum that is coming? Next, what is the quality of sputum? Okay, all these things are very important, which can point out towards a diagnosis. Okay. So as somebody has told, whether it is PTB or whether it is COPD, whether it is asthma and all, we can diagnose by asking various sections of this same symptom. Okay. Yeah, sputum color. Quality means sputum color and all. Okay. Fine. So quantity, quality. Quality means color. Okay. Any associated blood clots. All these things are very much necessary. Why? To differentiate between different reasons of cough. Okay. No, somebody can mute his mic actually. Who's this? Okay, fine. So where were we? Okay. Onset. So can anybody? So there are two types of onsets, right? One is sudden onset. Next one is insidious onset. Insidious onset. What is the difference between sudden onset and insidious onset? So let me show you a small graph. Okay. So let's say this is the symptom. This is the duration of time. Okay. So let's say the maximum onset of the symptom, if it is the peak stage of the symptom, so the maximum stage happens within seconds to minutes. Okay. So this is called as sudden onset. So this type. Okay. So the next type is called as insidious onset. Like the maximum onset of the symptom will be like it takes from days or like hours to days. Okay. So let's say this is the starting point of symptom. So for it to reach this peak, it took a considerable amount of time, like let's say 48 hours. One second, guys. Okay, fine. So it took up to considerable amount of around 48 hours or 72 hours or more than that. Okay. So this is called as insidious onset. What does this tell us about the symptom? So can anybody name what are the causes of sudden onset cough? Sudden onset of cough. Sudden onset cough. Reasons for sudden onset. Dust, very good. So instead of dust, we can say transient ischemic attack. Okay, which type of transient ischemic attack? Okay, reflex, very good. So reflex. So Telugulo polamarin antaru kada, that is very good. Next is dust or irritants. Can we call it as this? Can we call this as irritant? Irritant. So it can be dust, it can be coal, it can be any toxic substance, right? Any toxic gases. All irritants are there now. Yes, very good. Toxins inhalation. So these can cause. So foreign body. So let's say a child of age for 3 years or 2 years playing in the field or playing at his house suddenly turned blue and became is coughing very vigorously. So what could be the reason?
Allergen, exposure to allergen.
Or a child of 3 years who is playing at home. What's the most probable cause? That could be as choking. So that could be a small kid who ingested a foreign body, like any playing toys or something, chess coin or something like that, that went into his airway tract. It started irritating this fellow. Okay, if it is large enough, it can even kill this fellow, right? It can go and lodge into this main bronchus area, and it can kill that kiddo, right? So that onset. So it can be a foreign body. So next is insidious onsets, all the COPDs and all the COPD, PTP, so all these asthma episodes. So they take a considerable amount of time before going to the maximal onset, right? Then viral infections. So viral infections or viral upper respiratory tract infections, lower respiratory tract infections. Okay, all these things can cause can present as insidious onset cough, right? That is the importance of insidious onset cough and sudden onset cough. So next, coming to the duration. So duration. So why duration is important? So can anybody say based on the duration, acute cough and chronic cough, right? That there are both two types, no? Chronic cough. So a patient with the same age group, 60 years of age group, came to a hospital with the complaints of productive cough since 2 weeks. So what could be the first suspicion? What could be the first suspicion? Yes, very good, TB, tuberculosis. So in Indian setup, the first thing to suspect is tuberculosis. If you are living in foreign country, then lung cancer. Okay. Fine, understood. So other things you can suspect of is COPD. More than 2 weeks cough. In Indian setup is typical of tuberculosis. Very good. So acute can be mostly due to any viral pathologies or any bacterial infections and all. Okay. Or it could be, as you have told, like even peptic ulcer disease can, or acid peptic disease we call it as. So that can also cause this acute or chronic cough. Also, it can cause chronic cough as well. Okay. So even postnasal drip, there's some entity called as postnasal drip, particularly in case of chronic sinusitis and all. The patients will have postnasal drip, feeling of sensation of a drip, there is a drip happening in the posterior part of the pharynx. Okay, so that can irritate the respiratory tract and it can produce a cough, chronic coughs. Okay, so that can be seen in acid peptic disorders or even certain conditions like even cancers can cause this thing, right? So next, coming to the progression. So if the cause progression, coming to the progression, it is getting better with days, better with days. So generally it is due to, it is getting better with days. It could be due to better within hours, better within hours. It could be simple answer. So dust, toxic gases, reflexes, whole foreign body, not like all the other things. It can get better within outside. Why? Because the patient will quickly move out of the irritant gas region, or if this fellow is living in a dust region, he'll close the windows or doors, he'll put a mask or something like that. So that will make him better within hours, right? So coming to the within days means this could be due to a viral infection. So viral infections, most of the viral infections are self-limiting, except some viruses. Okay, so they come, they'll destroy some tissues, they'll do what all the nasty things they'll do. So they'll do and they'll go. Most of them are self-limiting. Most of them. Okay, viral infections. If it is too virulent of a strain, then it can cause symptoms or more profound symptoms, right? Next, bacterial. Some bacterial infections can also get better with days. So like there are days of MI cough will be there, but it's more due to pulmonary edema. It's a feature called as pulmonary edema, where in heart failure there will be pulmonary edema, which can lead to pink frothy sputum. The patient can't lie down on his own. Okay, when he lies down on his own, on his back, he'll get a vigorous cough and he'll cough out this pink colored frothy sputum. So it is a feature of pulmonary edema. Okay, so it is a feature of pulmonary edema. If we go a little bit depth, the scope of this the cough topic itself will take 2 or 3 sessions actually. So I'm not going too deep into the topics. So I'm touching just the surface parts. Fine. So better with hours, better in hours, I have told you, better with days. Okay, or worsening with days. Worsening with days. So that could be, as you have suggested, that could be tuberculosis. That could be any bacterial infection that is too virulent. Okay, too virulent strain in bacterial or viral. Fine. Are you guys getting? Are you sleeping? Are you guys are sleeping? Kitna Krishna. Where this OnePlus is, where this Realme 7-1C2. Only say these are many Realme phones are there. Is that Realme very popular? I thought Redmi was very popular. Fine. Yes, okay. So bacterial two virulent strains, they can cause worsening over days, right? TB can worsen over months. Even fungal infections can worsen over days to months. Okay. So forgive my rating. It's always been like that. Proper doctor whose writing is typical as per patient's expectations. Fine. Okay. So let's move on. So aggravating factors. Coming to the aggravating factors. So aggravating factors can be, so as I have told, in pulmonary edema. So lying down will increase the cough. Okay, taking certain posture, particularly in conditions like COPD, that to chronic bronchitis cases, even lung abscesses, will have increase or decrease in the posture. Okay, based on the posture, the patient might feel very comfortable, or it can aggravate the cough. Okay, so based on the simple logic is like, let's say these are the lungs. So let's say these are lungs. Let's say there is an abscess here. So this is the right lung and this is the left lung. So what if the patient lies down on the left side? So patient is sleeping on the left side. Then what happens? This drainage increases, right? So all these thing comes, all this pus and all comes to the lungs and all, and the patient will cough out vigorously. All this pus and pus material will come out of his lungs. Okay. So when, if the patient is lying on this right side, so what happens? This gravity takes effect on this side, right? The patient will feel comfortable. Okay. So based on the posture and all, so COPD, chronic bronchitis, particular chronic bronchitis, even lung abscess, certain types of pleural effusions, like in the pleural effusions, right? So where there is fluid accumulated in the lungs. So based on the posture, it can aggravate or it can relieve. Okay, aggravating factors and relieving factors. Okay, so coming to the diurnal variation or seasonal variation. Diurnal variation. So diurnal variation, coming to the diurnal variation. Can anybody say the examples? Which coughs are more common during night times, and which type of coughs are more common during daytime? Nighttime, daytime. Can anybody guess? People making popular. What is this? Okay, you guys are making really popular, guys. Okay. Bronchial asthma nighttime. Okay, asthma nighttime, allergic irritants daytime. Very good. So very good. So as you have told, so nighttime asthmatics will have episodes during the daytime. Allergens are more common. Why? Because we roam in the days, not in the nights, right? Allergy reactions can happen more in the during the daytime. Very good, very good. Okay, good. So coming to the seasonal variation. So seasonal variation. So asthmatics experience this very well. So during certain seasons, like particularly in the cold periods, asthmatics are very much prone to this, right? So they'll be very much prone to this acute exacerbations of bronchial asthma and all. Okay. So this is roughly a small briefing about this thing. 1 second. Okay, right. So this is brief about just one symptom. So this is cough. Based on this cough, so this is the topic. So how much time have we taken? How much time? 15 minutes or 20 minutes? Okay, fine. Let's continue. Let's finish it. So coming to the fever. Okay, fever is a very huge topic that takes a class on itself. We have a separate session for fever. Okay, based on these symptoms, so let's explore this particular case of 60-year-old male. So cough since 3 days. So you have asked for the onset. So this fellow has told you that the cough is in serious onset, or sudden గా అయితే రాలేదు సార్. సో in Telugu or what we call, so that is not a sudden onset. Okay, next, progression is gradually worsening of 3 days duration. That is a productive cough. That is a productive cough, type of the cough. There are no aggravating factors and relieving factors are not that prominent in this particular fellow. Okay, so the cough is of like quantity is less than 5 to 10 ml. 5 to 10 ml. Color comes to about greenish sputum. So color is about greenish sputum. Now what? So let's explore the other things. So fever, this fellow is also having fever. So fever is of high grade fever, high grade continuous fever. Okay, relieved by taking medications, by taking paracetamol tablet. Okay, so the fever is getting subsided by taking paracetamol tablets. Okay, continuous high grade fever. Now what? So you want to ask past history. So this fellow doesn't have any history of COPD. COPD is not there, asthma is not there. Okay, PTB history is not there. So this fellow is not a diabetic. So this fellow is not a hypertensive guy. This fellow has no history of past surgeries, no past surgical histories, no history of allergies. Suspecting it to be caused by an infection. Very good. So no past allergies, known allergies. Now what? So past this is also over. No similar kind of episodes in the past also. Now what? So you are suspecting an infection. Okay, so good. Now one of your colleagues is suspecting an infection. Now what? Now what? Any of them? So what should we do? So nobody is answering. So mainly maybe blood tests or might be pneumonia. Okay, could be the infection culture sensitivity test. Okay, sputum culture can be sent. Okay, fine. So what else? We don't have all day. Sputum culture can be sent. Okay, fine. Okay, so the question comes down to the three questions. Whether to admit this fellow, we'll do all the investigations and all. Fine. So whether to admit this fellow or should we treat this fellow on a OPD basis? If you decided to admit this fellow, will it be in a ward, general ward, or will it be in an ICU? So this is the main question. So this is the main question, right? So we can send the culture sensitivity, all these CBPs and all at on OPD basis, or you can admit the case also and we can send, right? So what should we do now? Should we admit this fellow or should we treat him home? Prescribe some investigations and we'll prescribe some medications and ask him to go home. Cheppanna. So okay, most of the guys are from Andhra, right? Okay, so tell me, what should we do now? The patient is asking, admit. Okay, tell me, my asked to admit. So can you guys change your names and all? Realme 99. Okay. OPD basis. Anirudh is telling that we should treat this fellow on OPD basis, and Realme 99 is saying admit this fellow. Since no aggravating factors, admit this fellow. Okay. What about the other guys? Only 2 of you guys have decided. So let's say this fellow is your own tata or grandpa. So one who have already told like I'm able to treat, sir. Now you suggest your own grandpa. What should, so your grandpa is asking, what should we do, son, grandson? What will you suggest him? So Anirudh is suggesting that to his grandpa to put him on OPD basis. Okay. So Realme's grandpa is he suggested his grandpa to go and get admitted. What about the rest? You guys don't have any. You guys don't have any grandpas, huh? Okay, fine. Okay, so let's understand the basics of this thing. So how can we decide? Both of your colleagues have given contradictory statements, right? So one have suggested IP, one has suggested OP basis. How can we decide to admit this fellow or whether to treat him on OPD basis? So for that, there is a small criteria called as curve 65 criteria. Okay. Okay. So as one of you guys have told that this is a case of pneumonia. So probably community acquired. Okay. Community acquired pneumonia. This could be. So for community acquired pneumonias, we follow this criteria called as curve 65 criteria. So what is curve 65 criteria? CURB 65. So let me quickly bring the thing with you guys. 1 second. Okay. So this is a small table depicting the curve 65 score. Okay. C stands for confusion. C stands for confusion. U for uremia. R for respiratory rate. B for BP or systolic BP. So next 65 stands for age more than 65. Okay. So this is called as curve 65 score. Okay. Each one carries 1 point. So one of the things that we have missed in the thing is general examination. Sorry, I didn't remember what's the age was. His age was around 60 years old. Okay, his age is around 60. So now let's start scoring this fellow. So confusion. So one of the things that we have missed is general examination actually. So general examination is also very important. Checking the vitals. Okay, so when writing in a case sheet comes before the general examination. So in general examination, there is one thing called as patient is conscious and coherent. So what do you mean by conscious?
Is the patient mentally alert or altered mental status?
Okay. So there is an actual definition for this thing. So consciousness means awareness of self and surroundings. Okay. Awareness of self. So am I aware of myself and Am I aware of my surroundings? So that is called as consciousness. Coherence means, as I have told, responding to the stimulus. So let's say I've given him a pain stimulus. Is he withdrawing from the pain stimulus? Or is he moving away? How is this fellow responding to the pain stimulus? Or how is this fellow responding to the verbal stimulus? Okay. So that corresponds. There is an objective way of measuring these things. That is called as GCS, or Glasgow Coma Scale for short. Okay. Glasgow Coma Scale. So it consists of 3 factors. So eye movement, verbal movement, and motor activities. Okay, EVM. So there will be like 4, 5, 6. Okay, each one will have score of maximum score of 5. This one will have maximum score of 5, and this one will be a maximum score of 6. So Glasgow Coma Scale, very good. So can anybody say what are the components of this Glasgow Coma Scale? Okay, it takes a little bit of time, so let's not go into this thing. Go out and search in the internet and know for yourself. So all these EVMs, or if you join the PEMS course, I'll teach you teach this thing in very detailed manner. We have a separate section for this thing. Okay, fine. In the emergency medicine thing, so we'll teach this Glasgow Coma Scale. Fine. So let's moving on. So Glasgow Coma Scale is an objective way of measuring how much of consciousness, how much conscious and coherent this fellow is. Okay. So confusion means, so if you ask him one question, this fellow will answer, will take it as some other question. So let's say if you ask him what is your name, he'll respond in back very slowly or very lately. He'll tell you that his name is Guntur, or his name is Tirupati, or his name is Mahbub Nagar. Okay, Tirupati is a common name. Okay, fine, I accept that. But so he'll say that his name is something, or his name is Apple, or something like that. Okay, so he'll give you mismatched responses. Okay, that is confusion, or he might not understand the question properly. Okay, so that is called confusion. If you ask him, he'll look bewildered. So he'll look here and there without answering the question. If this fellow is having confusion, we'll okay. So this where this fellow 60-year-old grandpa is there, no? So this fellow fortunately doesn't have any confusion. So no confusion for this fellow. So no confusion. So 0 points for this fellow in that matter. So we haven't sent for any blood tests, right? So we have to send for the. So we haven't sent for any blood tests. So many of you guys have suggested sending for the sputum culture sensitivity. That is good and all, but we need to test the other thing also. So that is RFT. So in RFT, that is also particularly urea. So blood urea nitrogen levels we have to assess. Okay. So if the one is more than 19, so this grandpa has a one of more than 19 actually. So that scores him 1 point. Okay. So his breath rate is around what have I told, 24 or something, right? So this comes to around 0. So systolic BP, that fellow is having a BP of 90/60, as far as I remember, right? So this is around 90/60, so less than 90, right? Less than 90 is 1 point. So, but considering his thing, let's take it as less than 90. Okay. And we have remeasured. So let's say this fellow is having around 80/50 or something like that. Okay. Let's take it like this. So his BP is also decreased. Okay. Now he's considering now his age. His age is 60 years old. So now 0 points. So total he got a score of around 2. Right? So based on this outcome, we can assess whether to admit this fellow or whether to admit him in ICU. Okay. So based on his score, what have we got? This fellow has a mortality ratio of at least 9 out of 100 people who have this score. 9.2% will die. Will surely die. Okay. So we have to admit this fellow. Okay. Particularly generally in the ward. Okay. So let's say this his age is also like more than 65. Let's say this Tata's age is around 65. Now this fellow will score another point, right? So now his score will be 3. So now we have to admit this fellow in ICU. Okay, understood? Clear?
Yes, sir. Yes, sir.
Yeah. So based on these things, so if this fellow is in, so coming to the management. So how do you manage this fellow? So let's say you are in a free clinic. So this fellow has the have we told you the purpose of PEMS actually? Have we told why we have started this course and all? So okay, introduction was given. Okay, why this course is started is to we want to treat the patients, particularly in the underserved areas, particularly in the rural setups actually, so where your hometowns are there. Okay, so let's say instead of going to an RMP, if he comes to you, so you have to take a reasonable decision. So whether to refer this fellow to the higher center where he can be managed effectively, or whether this fellow needs home, just a home treatment is enough or not. So just some basic knowledge is fine, just fine. This knowledge is not present with the RMPs, right? So all these facts will be there, who won't have any degrees and all. So they'll prescribe all the medications they want to. They'll put steroids for this fellow. All the steroids, they'll put all the antibiotics if this fellow. So this is a particularly bacterial kind of pneumonia, right? This needs antibiotics. So what if this fellow is not having any productive cough? So non-productive cough is there. So that could be a viral disease, right? And if his BP is more than 160 and his age is less than just as 60, so this fellow doesn't need any admission, and also that this fellow doesn't need any antibiotic therapy as of now, so because all the symptoms point towards viral infections. So viral infections, particularly in like body pains, headaches, nausea, vomiting, all these things are prodromal symptoms of viral infection, right? So we'll have acute onset, like 2 to 3 days, very high grade fever with chills and rigors. All these things point towards viral infection, right? Yes, yes. So all these things will have will point towards viral infection. So will we prescribe antibiotics to viral infections? Will you prescribe
Of course
antibiotics?
not.
Of course not. So what these RMPs and all these packs will do, so they'll put on, they won't even consider starting with augmentin or something like that. They'll directly put this ceftriaxone IV. They'll put the ceftriaxone IV. So they'll push steroid to say, reduce his symptom burden. So they'll put all these things unnecessary. This will become unnecessary burden on the patient, right? So that we want to prevent. So our main objective is to train guys so that all these quacks shouldn't have any. Shouldn't go to a quack. Okay, that's our motto here. That's why we have started this course. So why we chosen PharmD guys is because you guys have the basic knowledge of this, all the how these drugs and work, how these drugs works, how this anatomy of this basic anatomy is there. You have the physiology is there. We have the biochemical part is there. So biochemistry part is there. So everything, all the basic ingredients you have, everything anatomy. So all these basic ingredients you guys have. What we think you're lacking a bit is the clinical knowledge that we want to fulfill with this course. Okay, so this is the main agenda of this PMS course. Understood? So let's move on. So let's move on with the management of this thing. Let's move on with the management. So now this fellow needs admission, right? Admission. We have decided admission. So now what will we do? So because his BP is too low, we have to put him on IV fluids. So IV fluids, particularly fluid of choice in sepsis, conditions like this, shock is NS, okay, normal saline. We have to prescribe antibiotics. So particularly in IP cases now, so I have to put him on injections or parenteral route of antibiotics. So mainly ceftriaxone. Okay. So next, plus I have to give on respiratory quinolone like levofloxacin, levofloxacin, or we can prescribe injection AG. AG means azithromycin. Okay. Azithromycin is macrolide class, right? Macrolides. So this is fluoroquinolones. So either respiratory quinolones like levofloxacin, or we can prescribe azithromycin also. If this fellow is already exposed to antibiotic in the past 3 months, then this is the response. If this fellow is treatment naive or no history of any usage of any antibiotics, then we should give only either one of these is just enough. Okay. So particularly we prefer this antibiotics. Okay. Beta-lactam antibiotics. So beta-lactam antibiotics are just enough. Okay. Fine. This is thing. And supportive management. This fellow is suffering with increased respiratory rate, though. So we have to give some supplementary oxygenation for this fellow. So we have to put inhalation for this guy. So this fellow is also having fever, right? So give the supportive management in the form of injection paracetamol. So injection PCM or tablet PCM. This fellow is taking orally and all. Okay. So next we have to monitor the vitals. Okay. So then hopefully the patient will we have to take investigation part. We have to send for the culture sensitive sputum culture sensitive. We have to send for all the routine tests like CBP, complete blood picture, all the RFTs, LFTs. Okay. Why we need to check all these RFTs and LFTs? Why? This is a case of pneumonia, right? We have to take X-ray. We have to take ECG. Okay, X-ray is self-explanatory. Okay. So why are we taking RFTs and LFTs for this fellow? So if this thing worsens, so we have to set a baseline for this test, right? So baseline. So let's say you are suspecting. So what is the progression of this thing? So let's say the patient is admitted into ward, okay, general ward. So the patient is also having a kind of shock, right? BP is very low. So the patient is in obvious shock. So what follows shock? If the condition worsens, if the strain is too virulent, or if the antibiotic is not responding, if it is a multi-drug resistant variety of bacteria, then the patient will obviously worsen, right? So he'll go into a condition called as MODS. So what is MODS? Multi-organ dysfunction syndrome, right? So multi-organ dysfunction syndrome. So where liver can fail, even kidneys can fail, right? So we have to set a baseline for these parameters. Okay. So all these things and all, how to assess all these RFTs, how to assess liver function tests and all, we'll teach in the PEMS course. Okay. I have a dedicated section for this thing. This assessment of LFTs and RFTs, CBPs, how to interpret CBPs, how to interpret X-rays, how to interpret not everything in the ECG, the basic points of ECG, like what are the basic acute changes that we can suspect in a case of ECG and all, we'll teach in the PMS classes. Okay, fine. So let's quickly move on. So in the ICU, if the patient needs, if the patient is still worsening, now we have to put him on mechanical ventilation, right? For that, we need to take a thing called as ABG. What is ABG?
Arterial blood gases.
Yes, very good. So arterial blood gases. So arterial blood gases. So it consists of various things like pH of it measures various pH of the blood, it measures the PCO2 levels, carbon dioxide levels in the blood. It also measures oxygen levels in the blood, PaO2. Okay, it measures the sodium levels, potassium levels, so bicarbonate levels. Okay, all these things we can measure it to the ABG. So ABG is a little bit advanced session. So if the PaO2 is normally is around 80, 85 or 90, actually 90 plus plus or minus 5, or around you can go even up to 103 or 104 also. Okay, so PaO2 levels. So if it is less than 80 or something like that, we have to put this fellow on mechanical ventilator. Okay. So why mechanical ventilator is because we have to go in a graded manner. So let's say we put him on nasal cannula. So what is the maximum amount of oxygen you can deliver? So all these things will take a little bit of time. Actually, there is a thing called as FiO2, fraction of oxygen present in the inhaled air. Okay. So what is a normal fraction of oxygen present in the atmospheric atmosphere, in our normal atmosphere? What is normal FiO2? FiO2, what is the normal fraction of oxygen? How much percentage of oxygen is there? Very good, very good. So 21%. So we have 21%. So if we to take the fraction, so divided by 100, no? So that comes to around 0.21. So 0.21 is the fraction of oxygen that we usually inhale. So okay, so if we put him on nasal cannula, it can go up to 0.3. Okay, if we even if we put him on full flow, it can go. It won't go beyond 0.3. Okay, if we put Venturi mask, so Venturi mask or normal hood is there, no? It can go up to 40. Okay, in conditions like HFO, high flow oxygen are there, no? HFOs can give FiO2 of, so FiO2 of around 60. Okay, 0.6 it can go up to. Okay, there are certain things like CPAP masks. So CPAP is CPAP or BiPAP, positive airway pressure. Okay, continuous positive airway pressure, bi-level positive airway pressure. Okay, so CPAP masks. Okay, or we call it as NIV. Okay, non-invasive ventilation. So there is a mask like this, no? See, a triangular shaped mask which covers both the nose and the mouth, right? It can deliver up to 100% or FiO2 of 1. Okay, there is in mechanical ventilator we can control whatever we want to. So even in NIV also we can control how much percentage of FiO2 we can pump and all. We can set it in the mechanical ventilator. Okay, so we take those decisions based on this PaO2 level of the PaO2 in the ABG. Understood? So everyone is understanding, right? Am I rushing things a bit? Chaitanya. So Chaitanya, very good. 21%. So am I rushing or are you guys understanding everything? Yeah, good. Okay, very good. Okay, so only one guy is listening, huh? So understanding, sir. Thanks. Okay, Robert, very good. Okay, only 3 guys. Okay, 3 guys have responded. Okay, good, good. So this is the thing that we do. Fine. So this is the management. So let's say the patient has scored 1 or less than 1 or 0 or 1. Okay, now what we'll do? So we treat him symptomatically. So we prescribe him antibiotics. So as I've told you, so in the IP we have to give injectables. In the OP we have to give tablets. So particularly this fellow will give augmentin. Augmentin is amoxicillin. So it is a brand name actually, augmentin, amoxicillin plus clavulanic acid. Clavulanic acid. Okay, so you have to give tablet augmentin or amoxicillin plus clavulanic acid. If this fellow is treatment naive or previously in the last 3 months this fellow is not exposed to any antibiotics, then we have to give only single antibiotic. If he is exposed to some kind of antibiotics, then we have to add tablet with augmentin. We have to add either tablet azithromycin, any kind of macrolide. Okay, one macrolide, or this is or not an and, right? So either this or that. Okay, so or tablet azithro, or we have to give tablet any fluoroquinolones like levofloxacin or ciprofloxacin. Okay, any fluoroquinolones. So can anybody tell me all the macrolides you know? Pharma is your core subject. Can you tell me, can you name some macrolides? Can you tell me macrolides?
Erythromycin, clarithromycin.
Erythromycin, okay, good. Erythromycin.
Azithromycin also macrolide, yes.
Clarithromycin. So very good. So azithromycin, all these things are macrolides. Very good. Roxithromycin, very good, very good. So these are some of the macrolides. So most commonly available form is azithromycin, right? So it is very much available in our setups. Okay, very good. So this is the things. On top of it, we have to give supporting measures like all this tablet levofloxacin to suppress the cough and all. So antihistamines. So levofloxacin is levocetirizine is antihistamines. So it can be either tab forms, it can be a tabular form or in a syrup form. Okay. So here the cough is expectoration is there, no? So should we subside this cough or should we exaggerate the cough so that the sputum will come out? So there is a choice here, right? We can give expectorants. So can you name any expectorants, you know? Expectorants. Pharma guys. Expectorants, you know, of bromhexin. Oh yes, morphenicin. So very good, very good. So all these things are expectorants. So for this fellow, should we prescribe expectorants like ambroxol, or should we give antihistamines? Which one we should give? Should we give expectorants or should we give antihistamines? Dextromethorphan is not an expectorant as far as I remember. Ascoril is a brand name, not Ascoril has many forms actually. Ascoril D is for dextromethorphan, Ascoril LS is for liposoluble combination. So don't go into the brand. So come to the generic level, then you can explore all the brand names and all. So ambroxol, cofenicin, bromohexin. Okay, fine. Good. So my question is, should we give expectorants or should we give antihistamines?
Combination both.
Combination one is prescribing, which is ideal case scenario, ideal scenario.
Expectorants we can use, sir.
Yes, for any productive cough, we have to give expectorants. Why? Because so if we subside the cough, so what is a cough actually? Cough is a protective mechanism, right? Is it good or bad cough? Good or
It's
bad?
good actually. It's good.
Yes, yes. So nice. So it is good actually. So cough is good. Why? Because we are pushing all this foreign material out of our body, right? So if we subside the cough, what will happen? All this foreign material which is present in the tract, respiratory tract, will block all those respiratory tracts, right? So it will form these plugs and all. So it is a breeding ground for growing organisms. So all this sputum and all is a breeding ground for the organisms. So antibiotics are usually don't go or don't reach up to this core of this thing, right? Because there is no blood vessels in this particular part. So we have to what should we do? We should push them out of this respiratory tract. Okay. So that's why we should give expectorants in case of productive cough. In case of non-productive cough, we can prescribe antihistamines. Okay. So patients will definitely say, if you give only expectorants, what will he say? He'll tell you that doctor has given me some medication and all. Now my cough has increased very much. Now I am coughing very vigorously. This is a bad doctor and all. Okay. So now this patient won't come to you, come to your hospital next time. So that's why we usually prescribe a combination of expectorant and antihistamine. Okay, clear? So it decreases a little bit irritation, and that gives you the expectorants will push out all these things. So even mucolytics we can prescribe. Can you name any mucolytics? You know, mucolytics. So N-acetylcysteine, so even that we can prescribe, right? So in COVID times, most of the guys have prescribed this Pulmoclear tablets, no? Pulmoclear, that is the brand name actually, that contains this N-acetylcysteine. Okay, fine. So that decreases the tenaciousness of this mucus. Okay, if it is too thick, it will make it a little dilute. Okay, now it can be expelled very easily out of this system. Okay, clear? So this is topic brief about pneumonia topic. So do you have any questions? The session is almost over. Do you guys have any questions? Nestel system, okay, good. Mucinex is also a brand name. Actually, it's a brand name for Nestel system. Good, good. Any questions from you guys? Any questions? So no questions, huh? Either you have understood completely or you didn't understand anything. So what not to do? So very good. What not to do in a case of pneumonia? So red flag signs. So use of hypertonic saline. Yes, hypertonic saline is not actually used IV. It's actually used 3% NaCl. Use it for nebulization. What will it do is, so these are not fiber. So 3% NaCl inhalation we do actually. So what will it do is it will irritate that respiratory tract. So all these 3% NaCls. So what will it happen? It will enhance the cough production. So now all the plugs and all there. No? So if it is plugged and all, if the mucus is too tenacious and all, it will become a little dilute and it can be expelled out very easily. Okay. So that's why we'll give 3% NaCl nebulizations actually. So it is more used in cases of chronic bronchitis or in a case of chronic bronchitis. Why? Because in chronic bronchitis, there is permanent dilution, permanent dilatation of this bronchial tree, right? So there is permanent dilatation. So they have lost their ability to contract and relax. So now the only way for them is to make it diluent and make it expectorant. So make it if we irritate the respiratory tract, it will generate cough, right? So this cough will hopefully push this putum plug out of our body. Okay, so that is the use of hypertonic saline, 3% NaCl while giving for nebulization. Okay, so any more doubts? Any more doubts?
So what is the drug of choice in hospital-acquired pneumonia, sir?
Hospital-acquired pneumonias will have a separate thing. It's actually depends on the etiology actually. So what are the most common organisms which cause hospital-acquired pneumonia? Can anybody say hospital-acquired pneumonia? What are the various organisms which you know of which can cause hospital-acquired infections? So mostly hospital-acquired infections are generated through this. So this ventilator or use of any ventilators. Somebody has answered. So E. coli, Staph aureus is a good answer. So E. coli is very less common.
Pseudomonas.
Yes, Pseudomonas is also most common. So Pseudomonas is common. MRSA. Okay. Next, E. coli is a little bit rare. So Pseudomonas, MRSA. So there is one more thing. Yes, MRSA. So all these things can occur through hospital-acquired infections, right? So can anybody name what is the drug of choice for Pseudomonas? Somebody guys. Drug of choice for Pseudomonas. Acinetobacter, okay. These are all. E. coli is also okay, but not that common. No idea. Okay. Drug of choice is for Pseudomonas. Cephalosporins, no. So, what do you mean by MRSA? Cryptas, Klebsiella pneumonia. Klebsiella is also
Methicillin-resistant Streptococcus aureus.
Yes, methicillin-resistant Streptococcus aureus. Very good. So vancomycin is the drug of choice for MRSA.
Yes.
What about Pseudomonas? Pseudomonas. So actually somebody has answered. So it's actually PIPTAS. Okay, piperacillin plus tazobactam. So we can give that one. In beta-lactam class, we can give prescribe this PIPTAS. So PIPTAS is a combination for piperacillin plus tazobactam. Okay.
Okay, sir.
Yeah. Plus on top of that, we have to give. We can give one respiratory pilon also. Respiratory fluoroquinolones like levofloxacin also. We can even prescribe that one also. Okay. Any more doubts? Even if we can even prescribe meropenem, imipenem. Okay. All these things can also we can prescribe. Okay, any more doubts? Levofloxacin or ufloxacin. So what difference does it make? So you guys have to tell. Actually, you are more experts in pharmacy division than me. Levofloxacin or ufloxacin. So levofloxacin is more preferable. Why you have to tell me? Because you guys are experts in pharmacy, right? Krishna. Right. Any more doubts? So ufloxacin is generally preferred for GIT infections actually. So levofloxacin is more preferred for respiratory disease and even this renal disease also. Okay, urinary tract infections. That also we can prescribe unless we have to calculate the GFR actually for that. Little too advanced. It's beyond the scope of this topic actually. Fine.
Maybe some pharmacokinetic benefits of the levofloxacin.
Sorry.
Maybe some pharmacokinetic benefits of levofloxacin compared to ofloxacin. Half-life.
Yeah. Okay. Okay. Good. Right. Any more? Any more doubts? Okay. So with if no more doubts, so let's hand over the mic to Dr. Divina Sankirtana. So they'll address you for a bit, and then we can hopefully close the session within 5 minutes. Okay. So please bear with us. So we'll have something to address with you guys. Pause recording. Okay, please carry on. Right? If they have any more doubts, please let me know. There is a weekend doubt session also, right?
Yes, sir.
Yeah. Right.
Thank you, Dr. Abhishek sir, for sharing your knowledge. I think I know it's lunchtime for you guys. Sorry for making it too late. Okay. So this is the actual price range. How many of you think it is expensive? And how many of you think it is reasonable? Robert Wilson, Chaitanya, Dr. Chaitanya, Dr. Anirudh. So no one is responding. Okay, that's fine. So for more details, you can visit www.pems.choose.life or you can contact us directly. We are on Instagram as pems.choose. You can follow our page. We will share all the medical stuff daily. Expensive, and with this saying it is quite expensive in his opinion. Okay, that's fine. Everyone has their own views. But I think this is the cheapest. But I think this is the cheapest cost, cheapest price, because we provide high quality of content, and also we also give pre-recorded sessions to each and every program. For intense program, we give pre-recorded sessions. For virtual program, we give regular program also we give pre-recorded sessions. At the end of the course, we will have an exit exam. So if we get 50%, then we will certify. Then we will give certificates. One is certificate of course completion, and the other one is certificate as preventive healthcare provider. Okay. Thank you, Anirudh. Okay, that's fine. Let's close the session. Thank you, Arundel, for joining this webinar. So let us continue to make this kind of webinars every week. Stay tuned. Bye. Have a nice day.